Our strategy team. You too.
Nancy, you can go ahead.
Good afternoon, everyone. I'd like to call the meeting to order, and I would also like to note that a quorum is present, and I'm making sure with Tamika, a quorum
You do,
is
you
present.
have, John, it was just you and John, but Sharon Dumas, Artist Arnold, and Mike Summers are online.
Thank you, colleagues, for being online.
And Dr. Walker should be joining.
Okay, I also like to remind everyone that we are streaming via YouTube. You may have reviewed the minutes of the previous meeting. I'd like to ask for a motion to approve the minutes of the December 18th, 2024 meeting of the Health and Equity Diversity Committee as presented.
So moved.
Do I have a second?
Second,
Somebody online?
second.
All right, all in favor?
Aye.
Aye. Not seeing none opposed, motion passes. All right, next, we will do a roundtable of introductions of the members of the committee. And this was actually my request. We have a lot of new members and a lot of good work that's ahead of us. And I thought it would be a great idea just to take a moment to introduce ourselves, tell a little bit about of who we are, because that's the beginnings of really knowing who we're working arm in arm with in some really good, again, important work. So why don't we start with our one of our fearless leaders over here, Dr. Marugu, and then we'll just go around.
Thank you, Nancy. Good afternoon, everyone. I think I know most folks, and most of you probably know me. I'm Srinivas Marugu. I lead the Institute for Hope here at Metro. I've been here just over a year now. I'm an internal medicine doc by training and spent several years in population health leadership over the last 15 or so years. And I'm coming to this work with a great deal of enthusiasm and working on population and community health. I don't know, is there anything else you wanted us to for me to say?
A little bit of your background and why you're interested in this committee.
Okay, yeah, thank you. So when I was in practice, I practiced in the central neighborhood here in Cleveland and was before the Affordable Care Act and before we had an all-encompassing term like social drivers of health. Those were the primary things that stuck out to me as things I couldn't control as a primary care doc, and became really interested in working with community organizations and partners outside of the four walls of the healthcare system. And that continued into my next role. When I left practice, I moved over to United Healthcare's Medicaid Managed Care Plan for the state of Ohio, and continue to do work mostly with community partners, including in housing, food, transportation, the predominant social drivers, and builds population health programs, work on disparities, i.e. the subgroups within any given population that has disparate outcomes was always a central feature of the mandate from the Department of Medicaid for us. And personally, it was important to me as well, because I had treated very many patients who had disparate outcomes as a result of what subgroup they belonged to. It wasn't their clinical diagnosis that determined it. It was also the conditions of life that they experience outside of the four walls of the healthcare system that determined it. And so have always been very interested in it. I'm also coming with a very data-driven and quality improvement mindset to all of this work. I think there's a lot of value in studying processes deeply, studying systems deeply, and then intervening appropriately. So I'm very excited to really be part of this group. I worked very closely with Nancy in picking the membership for the group to have representation across so many dimensions of our patients, our community, our health system. There may yet be room for inclusion addition to the membership. So I kind of wanted to put that out there too. This doesn't have to be the end all be all of this group, but it felt like this was a good starting point. So excited to work with all of you on this. Nicole, I'll pass this way, so you're not the last person.
Okay, thank you.
You're a good friend.
It's just equitable.
Wonderful, I'll pass tomorrow afterwards. So my name is Nicole Lukama. I'm the Chief Learning and Culture Officer here at Metro. I'm in HR, and I'm your HR representative on this committee. And I have been in HR for 20 years, but I started my life in public health after my master's is there, and supported the state of Ohio on Healthy People 2000. That was a few years ago. But that's when I started my foray into healthcare, and my interest is not just about employees, but obviously culture. And we know if we support our employees in the same way we support our patients, we're going to have better outcomes. So that's why I'm here. Thank you.
Hi, everyone. My name's Mara Wilbur. I'm Associate General Counsel here at Metro Health. I am the legal partner for this committee and report up through James. I've been with Metro Health for about 4.5 years. I came here after being within the healthcare and life sciences of a law firm practice for about 6 years, because I really wanted to get involved in the Institute for Hope, the value-based care, and the other population health initiatives that Metro Health was involved in. My background before going to law school is I got my master's in bioethics and was focused pretty heavily on patient advocacy models and specifically public health approaches to medicine. And in my role here, I've been able to support a lot of the public population and community health initiatives across the system, from managed care, Eye for Hope, care coordination, clinical services, and love everything that Metro Health does in that space.
I'm with Eric, no. I am James Wellens. I am the Chief Legal Officer. I am in my 8th month here at Metro Health. I come from practicing law for over 30-something years. I had worked at Temple Health System in Philadelphia. Some of you may know it's also a safety net hospital. One of the things that drew me here to Metro Health is that when I started to learn about the Institute of Hope and the mission here and all the various things that this institution does, I became enamored and really wanted to be a part of the organization. So I'm happy to be here, and I will pass it on to Robin.
Thank you. I'm Robin Baer. I'm the Executive Director of Internal Audit Services. So I lead our internal audit department here for the system. I just passed my 5-year work anniversary at Metro Health. So that's a big milestone. But prior to Metro Health, I worked specializing 12 years in internal audit at a Big 4 public accounting firm. So my role here is to help. I have my risk hat on. And so as the committee and management begin to launch various initiatives or activities, I can help be a lending partner from an eyes and ears perspective as to how the system's moving. Do we have the right control environment in place to help protect and mitigate risk across the system?
Thank you, Robin. So a little bit about why I have had such interest in this particular committee and why I wanted to serve on this committee. One, I was raised in the Clark Fulton area, and Metro Health was the hospital that my family used, and I have had family members that were born here, family members that have passed away here. This is part of the community, part of our life. And so any way that I could be a part of continuing to grow the hospital in its excellence and its ability to serve every person in our collective community, I will do so. That's what I truly believe in. And then I also, in terms of population health work, I was at Case Western Reserve University in the Department of Epidemiology and Biostatistics for 8 years, working on this very type of work and research around health disparities in the Latino and Black community. So this is just something that's really interests me. I'm in health and human services, and this work, I live and breathe it every day, and why not do it for fun as a volunteer as well?
Thanks, Nancy. Good afternoon, everybody. My name is John Corlett. I am a retiree after almost 50 years of working in the health and human service space. I started my career mostly in women's health. I worked for Planned Parenthood for like 15 years all around Ohio, and then went into broader health and human services work. I'm also a gay man, so that's a big part of who I am and my world. I've been out for, I think, 46 years, although I didn't realize you just didn't come out once. I come out all. And then once everybody would spread the word, everybody would know. I worked at Metro Health when actually we established, I guess, the predecessor committee now of this committee. And I've always been a big supporter of it. I thought it was important then because I thought it was important that the whole community benefit from the services and activities of Metro Health, not just parts of the community. I get all my healthcare here. So I've been at almost, I think, every site in the system, I think now, at one point or another. And so I'm very passionate about this place, the people who work here, its patients, and our mission. So.
Hi, everybody. My first name is Ade Banjo. I go by BJ, though, so please call me BJ. Not even my parents call me by my first name.
Or if you're in trouble.
I work on our strategy team here at Metro Health, and so I've worked with many of you guys in the room on different things. I've been here for about 4 years. Prior to here, I was actually in the mortgage industry. But even before I knew the words, so I was licensed in 20 some states around the country, most of them I'd never been to, but just from a loan amount number or a zip code, I knew exactly how the conversation was going to go. And so that was just kind of early cueing into what we're going to be addressing here in this committee. And then I made a change and got my public health degree at Case Western during the most interesting time, which was COVID happened. So what a weird time to be learning public health, but a great time to be learning it. And Dr. Nagel is actually my capstone advisor, and so, yeah, anything I learned from her. So. We know who, yes. Yes. But since I've been at Metro Health, my focus has been a lot on this type of work through the community engagement team, through I for Hope, through CCH, and through a bunch of other venues. So I'm really happy to be here and add to the conversation.
So Chrissy Alexander, I'm the president and CEO. As I think about, I'm here because I'm on every committee. Having said that, this would be the committee I would choose if given the choice, because it resonates with what has been the real focus and passion of my career. So similar to Srinivas, I'm a primary care physician, family medicine, still practice, albeit a really small amount. But maternal child health is kind of my sweet spot. And but even more than that, noticing who could make it in for appointments and who can't, and the reasons why, and all of those sorts of things. And as a family doc, I view the whole person, but also who they are as part of their family and their community and their culture, and whatever faith systems they may be connected to. And so really, I started noticing a lot of the same things, and felt like one of the barriers was the fact that we were waiting for people to come to us instead of us going to people. And so that also has become my passion, and thus grew, correctional medicine and the school health program and docs on the street and, all of those sorts of things, just as a way to say we have to get to where they are, and we have to address every barrier that we can so that we can make sure all of our patients do well and can live their best lives.
Nabia Shahari, I'm not a primary care physician. I'm a urologist.
But you are at heart.
For the last 23 years, I've been in healthcare administration and management, and I've been on a mission to improve the health and wellness of the population. Joined Metro Health in 2016, so completed my 9th year. This is my 10th year as of April 1st here at Metro Health. Created the Population Health Innovation Institute that did not exist prior to my arrival. And then 2019, started looking just before COVID. How can, because my background was in the Kaiser Permanente, everybody was insured here in Cleveland, Ohio, knew kind of how to do population health, came to Metro. There's a little bit of barrier to get to those patients. So it is because of the need and that we need to go upstream to really resolve the barrier and improve the health and outcome of the patients and the communities, that we created the Institute for Hope. That was 2019. And for those who are new to this group or not fully familiar with the Institute for Hope and why it was created, it was specifically created into a population health mindset, and that is to improve the health of the individual and the community. That's what the H is for. Provide an opportunities, and by providing the opportunities, meaning removing the barrier that prevent them from getting the health. And then the P is for partnership, because we knew we could not do it on our own at Metro Health, and we need to partner with others in the community. And the empowerment was the E, and that's very important in our work, because we want our patient and community to be healthy on its own and not always depend on us to remove those barriers for them. So that's why the HOPE stands the way they stand. And that was 2019, and this is 5 now years later, and we're still here.
So that's a good one. I remember all of that. So I'm Joe Golub, clinically a trauma surgeon and surgical intensivist. I'm currently the Chief Quality and Safety Officer. I've been at Metro Health taking care of this community for 22 years. And I think, if you think about population health and you think about disease, oftentimes you think about diabetes and you think about prostate cancer and you think about the disparities of care, but trauma is often overlooked, and it's a disease. Trauma is truly a disease. It's driven by the social drivers of health. I've seen it firsthand my entire career here at Metro Health. And unfortunately, I really haven't seen any changes in that space over these years. So I've always been driven to population health and trying to improve the outcomes of trauma patients. We're often very, very good at getting them out of the hospital, but we're not good at getting them out of the situation that put them in the hospital. So we try to spend a lot of time at trauma here to do that. But obviously, disparities and equity work is quality. You can't do quality without having those in it. So in my current role too, health equity and looking at disparities is critical to what we do at Metro Health.
Hi, I'm Kate Nagel. I wear 2 hats, like many people in this room, but I am the CEO of our federally qualified health center, Link, and then I also oversee our community health enterprise on the system side, which pulls together the majority of our front doors, is what I would say, from a patient perspective. So the call center through behavioral health, primary care, et cetera, in between. I'm pretty sure Srinivas asked me to be on this, so I would let him go out on the mobile clinic, but. Doug asked me to go places. I have been with Metro since 2018. Prior to that, I was at Care Alliance, which I got to work with many folks in this room on a number of different initiatives, especially the waiver. John Corlett is actually one of the very first people I met when I moved to Cleveland, like 25 years ago, back at the Federation. So long ago, it's not even called that anymore. And prior to Care Alliance, I was at Cleveland Clinic, where I ran the community-based population programs. It was the first chair of the Cuyahoga Health Access Partnership, which I know, which is unfortunate that we might need that again. And so I've worked with a lot of people in and out of this room in my Metro world and before. So I have a passion for public health through teaching and programming, and then also for homeless outreach and housing care. That's my dissertation was in, and so I like to think I know a little bit about it. So I'm happy to be here with all of you, and thank you for asking me. And yes, you can
Thank
go
you.
out on the mobile. It's only half a day and Nabil has to be
Okay.
Different meeting.
Hello, everyone. I am Tamika Rose. I am Dr. Alexander's Chief of Staff, meaning the Systems Chief of Staff. I'm also the board liaison, so I am one of those people that wear two hats. If I were not in either of these roles in a real role, I would be, and I'm not saying that this is a real role, but this is a real role, but I just say like taking care of patients or, you know, things of that nature, because I was formerly the Vice President of Government Relations and also the Manager of State Government Relations, where I met Kate and worked for John. And that's when we created the Metro Healthcare Plus waiver. Also worked with Dr. Alexander in that stint, which was about 13, 14 years ago. And created the Docs on the Street through a grant called MedTap. And that's how I met Dr. Alexander. And after I did all of that, I took a sabbatical and worked in the city of Akron for about 7 years on maternal and child health. So I did a lot of work around infant mortality, decreasing the infant mortality rate in Summit County. And then I came back to be the board liaison, which was supposed to be a very easy job. But here I am, and everything's running smoothly now. So glad to be a part of this committee. Looking forward to all the great work that you, Nancy, and Srinivas and this entire team will put forward going, you know, as we move forward in this new world. Thank you.
Tamika, can you help me with the folks on screen?
Yes, I can. So I'm gonna just go by the way I see you. So we're gonna start with Artis.
Pleasure to meet everyone. My name is Reverend Artis Arnold. I'm a managing director at commercial division at Huntington National Bank. You know, part of my reason for being a committee member at large and just attending today is, you know, part of Huntington's vision is to be a people first, customer centered bank. So we have two pillars in that, and part of that is, you know, building a caring and inclusive, you know, bank and working with our community partners to help that come to fruition. So in this role, I have the opportunity to serve Metro Health. In my secondary role, I'm an ordained minister in the Glenville community at Bethany Baptist Church. I'm the youth minister there, and I very much believe in an inclusive ministry. So again, being part of this committee is, in my view, part of being a good servant leader for the Cleveland and Cuyahoga community. So thank you.
Dr. Thornton.
Good afternoon, everyone. My name is Daryl Thornton. I practice pulmonary and critical care at the Metro Health System, and I direct the Division of Pulmonary Critical Care and Sleep Medicine here. I also direct the Center for Health Equity, Engagement, Education, and Research, affectionately known as CHEER, like 3 E's, which people may not know, but it was one of the 10 original centers for health disparities in the nation, and centers of excellence designated by the National Institutes of Health. It was started in 2004. I came in 2005 and have been privileged to be a part of that since. A few years ago, we became part of the Population Health and Equity Research Institute, which joins together 2 other centers here at Metro Health, including our informatics center and our center for public, we call it CHIRP, Center for Research and Health Policy as well. I've been doing health disparities research since 2000, largely because I was interested in finding interventions to improve outcomes and getting tired of hearing more and more about how often disadvantaged populations have poor health without any really clear solution. So I've spent most of my career not just finding more disparities, I think that's the easy part, but actually trying to develop novel interventions to eliminate them. So it's a privilege to be here.
Thank you. Ms. Dumas.
Okay, my name is Sharon Dumas, and I'm not an official member of this committee, but it does draw my interest. I'm a long-term supporter emotional supporter also of Metro Health. I have always been in admiration of what this hospital does in the community and how they deliver these services, and erasing disparities and the outreach that you do and assessing the needs of the community and being able to meet those needs and evaluating yourselves on how to do that to go forward is just of tremendous interest to me. And I have a great admiration for what you do. So just a thank you and an appreciation, and I want to be here and get a little more in-depth understanding.
Mr. Summers?
Yeah, good afternoon, everyone. My odyssey to this moment is probably a little different. I spent 32 years owning and operating a manufacturing company on Cleveland's west side, and then unexpectedly became mayor of the city of Lakewood. And in that in that journey, particularly in Lakewood, I was introduced to the notion of the social determinants of health. And I began to appreciate and understand the implications of that model as sort of a template for how a city could think and behave. Just about every core service that a city delivers to its citizens is driven by a demand. And that demand often is defined by the people who live there and what circumstance they find themselves. So it's an interrelated loop of how the city supports the citizens and the citizens demand support from the city, and how you could improve both by focusing on the citizens in particular. And like most circumstances, probably 80% of the demand for urban services come from the most vulnerable citizens in that city. So creating a focus on what's going on in their lives and the key drivers of whatever behavior it is that requires them to be served by the city or others was a wonderful notion of how you could focus your energies to take the whole platform of quality of life up for everyone. So from that moment on, and that was probably about 8 years ago, I've been really intrigued and a student of the work of this committee and Metro Health in general. So I'm delighted to be part of the discussion and continue to learn more about it.
Thank you. Mr. Chajetsky?
So I'm like other members of the committee, I'm a retiree. I served 32 years in the armed forces, and I actually started my career at Metro. Met my wife at Metro. She was at the nursing school, Cleveland Metropolitan School of Nursing. I actually proposed to my wife while she was sitting in front of the dorm on Valentine Avenue. So when I retired from, yeah, well, you know, you have to pay back. So I was the first male to graduate from Ursuline College Center for Nursing, where our mission was vision, value, voice, having the vision to help others, provide value to the community, and provide a voice to those that don't have a voice. In the military, I provided care in almost all the continents of the world to populations that are very needy of healthcare. And as a nurse, I was a critical care nurse for the majority of my career, and actually that's why I ended up joining the military, because I joined as a critical care nurse and ran the emergency room for the 101st Airborne during the first Gulf War, the 86 DVAC. So I'm just trying to use my experiences. Like Sharon, I'm not a member of the committee, but I have an interest in the committee, so I decided to participate and see what value I can bring to this committee as well.
Dr. Moreland?
Hello, everybody. I'm Connie Moreland. I am an OBGYN by profession and have been practicing, I guess, the traditional OBGYN work for many, many years in Chicago, and gradually progressed from the generalist work to becoming an OBGYN hospitalist in a large urban setting, not unlike the setting that Metro Health finds itself in. And I think over the years, I just, began to appreciate more and more the importance of a health system and the potential impact that it can make on the community in terms of being a beacon of hope for the community. And as many other people have pointed out, the the need for us to reach out and to meet our community where they are. And so I find myself here at Metro Health in the role of the VP of Provider Pipeline Development and Engagement. And that's quite a bit of a mouthful, but I see my role as advocating for my colleagues, building strong medical teams, trying to do the best that we can to make sure that we have providers that are uniquely qualified and situated to meet the needs of our patients, and doing our part, I guess, to keep us healthy and well as providers so that we can be as engaged as possible with our organization so that we can have the best possible outcomes for our patients. So I'm happy to be here and I hope I can serve the committee.
Thank you. Mrs. Garcia?
Hi, Ms., please.
Ms.,
Or
sorry.
Lola, even better. So, new member of the Board of Trustees, so not officially a member of this committee, but really excited for joining this committee, honestly, because I came over from the foundation board for Metro Health. And so this is, and of course, I have a daughter walking in right now. Go to Girl Scouts. It's fun. He's like, I'm late. I'm like, then go. So, very excited. This is my first meeting of this committee, so excited to be here.
Thank you. Well, I will go Ramona Brazil. I don't want to mess up anyone else's name.
Thank you. Hi, everybody. And sorry, I'm not with you today, but that is because I'm out in the community, getting ready for a community conversation that we're going to have tonight at Warrensville Library. I am Executive Director of Community Health Engagement and Impact. I've been at Metro Health for the last 3 years. I am a registered nurse by background. I started my career as a labor and delivery nurse, and maternal child health is still my primary passion. I spent almost 20 years in public health at the Cuyahoga County Board of Health, and a variety of roles. And in my very first role there as a lead poisoning prevention case manager, during my very first home visit, I can still remember the house I was on the street I was on in Cleveland Heights. And I remember thinking, if I was a public health nurse before I was a hospital nurse, I would have been a different nurse in the hospital, because it was then that I understood so much of what our families were truly facing. And while I, of course, did well in nursing school and passed the boards and all the things, and what I taught people was clinically correct, accurate, that in many ways what we were teaching them wasn't possible for them to actually do and achieve, because we didn't understand the circumstances in which they lived and the challenges that they faced every single day. And so, before we had the words of social determinants of health, I think a lot of people have been in the work for a very long time. And, I spent I left the Board of Health after COVID because I was burned out. But I came to the hospital that I thought was the best partner during COVID, which was Metro Health. And that's where I got to know Katie Davis and Dr. Watts, and the work that was being done in the shelters, and the work that was being done in parking lots and testing, really helping us out when we did not have the capacity. A little known story that I'd like to share is that people don't know is when COVID first came out, there's 2 different types of vaccine. There's Pfizer and there was Moderna. And Pfizer had to be kept in ultra cold freezers, and we did not have one. And we, of course, couldn't buy one either because of supply chain and cost. And the hospital system that stepped up to store our COVID vaccine was Metro Health. And it's because of that our county got more vaccine than it would have had if that didn't happen. So I'm very proud of the work we do here. It's very personal to me. It's a personal passion. So that's why I'm here. Thank you.
Thank you. Allison?
Hi, good afternoon. I am not on the committee, so I think I'm an observer today. I'm not sure. But I'm Allison Poulios, the SVP, Chief External Affairs Officer. So I have been with Metro Health about 6 years now and have a background in public service, working both on Capitol Hill in Congress for about 13 years, and then prior to that, working in and around the State House in Columbus. And so just in my role, I take public service seriously. And that is what attracted me to Metro Health, was that I would be able to continue really helping people and getting involved in the great work that Metro Health does. So I'm very excited to be working with Ramona and her team, as well as government relations folks, on all the work that we do in the community and the difference that we're making.
So before we move to Reverend Minor back there, Dr. Walker is actually on the call, but he has his camera off. So how would you like to work with that, Nancy?
So we just called him out. Tamika did, let's make that clear. So we can invite Dr. Walker. So nice to see you.
Obviously, Tamika believes I can't fire her, so. Afternoon, everyone. Sorry, a little bit late, but what should I tell you my background? All you know my background, so it'll be boring.
Right. Why don't we, Dr. Walker, if you could just give us a little bit about why this committee, why is it important to you?
Sure, happy to. This committee is a lot about what Metro Health is about community health. I mean, my head part of my career has always been about community health, which is near and dear to my heart. Populations, things like that. I mean, we've always been about going into different areas, different communities, trying to see what issues are and doing what we can to improve their health. To do that, you have to understand the different populations and and areas. And I think that's what this committee is about, going in to different areas, populations, understand what their issues are, and trying to see how we as a system can help them improve their health. So to me, that's the whole benefit, the whole design, the whole idea of community health. So I could not be involved with this.
Thank you. Please don't fire me. We'll go over to Reverend Minor.
Yeah, thank you so much. So I often tell the story that I've been at the hospital for 8 years. I was on the board for 2 years, and then I've been here for 6 years. But actually, and I think Dr. Walker would really enjoy this story. I actually began working with the hospital back in 1980, and I was a young, fresh out of graduate school, working in public housing. I came up with a concept to place drug and alcohol treatment in public housing. And we developed Miracle Village. And I think that's a story that the hospital has forgotten, So after that, we developed, John probably recalls this too, we developed, and Dr. Walker knows, right after that, there was a second grant in which there was a grant for primary healthcare in public housing. And so we had 3 sites, Riverview, Lakeview, King Kennedy, and that kind of set the stage for Care Alliance. And so, yeah, so so my history here has been really good. So I work on Mona's team, been in a number of different departments. We finally landed somewhere, feel really good at where we are. Have been doing a lot of faith-based engagement. So from my doctorate degree to most of 30 years in the work, I pastored a small mission-oriented church, right? Most of my professional life has been public-facing and kind of known around the country for really doing faith-based community organizing, where you equip pastors to move from pastoring and preaching to what we call the practice of ministry. And so we've done some really good work here in the last 6 years. I think the highlight of that, outside of the clergy cabinet that we have, in which the CEO meets with high impact pastors. I think one of the biggest stories was during the COVID, in which, I was able to work with a host of different players too, but we actually got 50 congregations to open up their doors and their parking lots to allow us to both test and do that work. So I'm very happy to be part of this team and hope I can add something to what we're doing.
Hi, I'm Matt Kaufman. I've been with Metro for 23 years now. Started here as a nurse in the trauma ICU. Got to work with Dr. Golub back in the day when he was a resident and I was new. And that's really, as Dr. Golub pointed out, that's where you really start to see the effect the community can have on our patients. And that's where you start to feel that passion for that. I eventually moved into the quality programs here at Metro Health and was with the Quality Institute for a long time. And I actually had a great opportunity to really set up our mass vaccination clinics for COVID. So I had that whole opportunity to see our teams in action supporting our community. We did a lot of homeless shelters and community events and doing all that. And that's really started where you continue to see the problems that we have to work with. And so I think that drive for quality and the need for improvement we've got a lot of work to do.
I'm Will Doobie. I'm the Vice President for Communications here at Metro Health. Thank you, Nancy, John, and Srinivas for inviting me. My background, well, I've been at Metro Health since 2023, so I've been here about 2 years. Prior to that, my background is in government and higher education for most of my career at Cleveland State University, where I was for a fair piece of time. I have a passion for this work, a passion for community service. That's one of the reasons I've taken the jobs I have over my 25-year professional career, where I thought I could help people and make a difference. And when this opportunity came up, it was just a perfect connection for me to be able to work with an institution that cares about the community the way it does and provide the support it does. And I'm happy to be part of the team along with Bridget that gets to tell our story on a regular basis to all the various audiences that we want to know of all the great work we're doing. So I'm happy to be here.
Hello, I'm Bridget Barrett. I am the Chief Marketing Officer. I joined Metro Health in 2021. I actually do not have a healthcare background. I have a politics degree and I spent my entire career in retail and consumer packaged goods. But I spent the majority of my career at Starbucks Coffee Company. And then I moved back to Cleveland. I grew up here. I was a patient when I was a child and my parents were patients here. And I have a lot of very strong family connections to this institution that I absolutely love. And I think one of the things about coming from Starbucks, I moved back to work at Great Lakes Brewing Company, leading their sales and marketing team, is that every place that I have worked has been mission driven. These are all places that you might think are just about the product, but they're not. Anybody who's from Cleveland and knows Dan and Pat Conway know that they are very passionate about their community. They're very passionate about creating a legacy in the neighborhood. And Starbucks was the same. It wasn't just about the coffee. It was really about creating great experiences and places for people to gather and to leave the world a better place. And so to be able to take all of that retail experience, all of that consumer background that I have and bring it to something that I actually really love. And I was introduced to healthcare also by Dr. Nagel, because I was on the FQHC board when that first started. And I remember Ron saying that there were no dumb questions. Remember that, Dr. Walker? He said I could ask anything I wanted, and I did. I asked a lot of really dumb questions, but I learned a lot. And the fact that I actually get to work here full time now, the saddest thing was that I had to give up that board thing, but I loved it, and I'm really happy to be here full time now.
Good afternoon. My name is Greg Zuka. I am the Executive Director of Community Transformation and Real Estate. So I wear several hats as well. One of my main roles really is to look at how can we leverage the work that we're doing both programmatically, but also in terms of physical development, how we can leverage that to improve the overall health and well-being of our neighborhoods and communities. Because as many of you have talked about, one of the biggest impacts of, or one of the biggest predictors in your life expectancy is your zip code. So place really does have a matter in overall health and well-being. And so if we want people to be healthy, we need to make sure they're living in healthy communities as well. As part of that process, I also oversee one of our related entities, CCH Development, which is a nonprofit development corporation that helps Metro Health to achieve those kind of community investments. So an example of one of our projects is Viasana. So that was a 72-unit affordable housing project that we did in partnership with many community partners. I also oversee all of Metro Health's real estate portfolio. So I have to handle all of our wonderful landlords and argue with them about stuff, but yes. Really my background is in community and economic development. I've had, several careers, whether working at the county department of development, local nonprofits, but this really is my dream job. I've been here for 7 years, and I've never seen or kind of experienced such a great group of people, such great camaraderie, such great commitment to not just serving patients, but the community. And it's just very infectious in a good way. And I really think that, healthcare institutions, especially a leader like Metro Health, has a great potential for impacting neighborhoods and communities and can be that leader here in Cleveland, but across the country.
What he said. I'm Kathy Plummer. I am the Director of Grants and Proposals in the Office of Strategic Philanthropy, otherwise known as the Metro Health Foundation. I am about to finish my 23rd year here and cannot imagine working anyplace else. Spent 10 years at the Cleveland Clinic doing much the same work, but really felt I found a home when I started at Metro Health. My job is a matchmaker. I get to take wonderful projects that I've worked with many of you on and find a partner to help move them forward financially. And I look forward to doing that a whole lot more as part of this committee.
Hi, everyone. My name is Veronica Graves. I'm an executive assistant and board clerk. So pretty much my role is just providing staff support for the committee. So even though I don't have any decision-making abilities in this committee, I can say that Metro Health is truly a pillar of the community. As a child, I've been on the receiving end of Metro Health in the community. Reverend Minor, he mentioned Miracle Village. So I lived in public housing as a child, but I can say that it was really just having the opportunity to access healthcare in the community, and I didn't have, because everything was already far to obtain. So it was just really wonderful to just go across the street, really, and when I needed healthcare services, it was always available. So, and I've been in Metro Health for, it'll be 20 years in May. So I was born in Metro.
We know your age now.
It's the star though. She knows been working.
Thank you, Veronica.
No problem.
And I want to thank everyone for buying in and giving me and giving this committee the time to tell us a little bit about yourselves and your passion. I think it's very important in the type of work this committee is going to embark on, that we get to know the fascinating, wonderful history and perspective that many of us bring to this work. So again, thank you for indulging me in just a little bit of extra time and the welcome, so that again, we get to know each other on a different level. So with that, let's get into some more work. As you may be aware, the committee is being renamed to Population and Community Health. And so I would like to spend a little time reviewing the committee charter that we've established, and just want to say thank you to Dr. Marugu, to Mara, and a couple other folks that have jumped in and helped us just put one together. Now, Tamika, has everyone seen this, the charter?
It was.
Because I don't want to be one of those people that reads like 2 pages worth of things, but I can. Why don't I read the purpose?
Okay.
And then we can take it from there in terms of doing a deeper dive in questions, suggestions, on the charter that we've put together as a draft that we can now discuss as a committee. So, if you can give me 2 minutes, I think I'm just gonna read the purpose of our committee, the Population and Community Health. The purpose of the Population and Community Health Committee is to promote and ensure compassionate and holistic care for all patients within Metro Health System and the communities served. The committee will work collaboratively with Metro Health's Board of Trustees, administration, staff, and community stakeholders to identify and address population health outcomes, develop strategies to improve health outcomes across all subgroups within the populations Metro Health serves, and provide healthcare access and delivery for all. After that, we have some very specific responsibilities. But in terms of just purpose, just would like to get a little bit of feedback. How does it resonate? Are we missing something? Is it clear after you read the purpose on what we want to embark on? And I open it up to the committee.
I think it's generally pretty clear, Nancy.
Quick question, Nancy. Mike Summers here.
It's Mike.
When we use the term holistic care, is there sort of a clinical definition that we generally could agree on? What are the boundaries of that care in terms of Metro Health?
Anyone want to jump in? Because I will answer as a nonprofit person, not in the clinical.
So I guess when I think about providing compassionate and holistic care for our patients, it's that we are not just transactional in our interactions with our patients, but we're really looking for all of the things that impact their health and how do we partner with them to address it. So as opposed, for instance, somebody is admitted to the hospital with pneumonia, we don't just look at the pneumonia, but we also delve into, do you have access to food? Do you have stable housing? Are you able to get your medications, right? It's looking at that bigger picture as opposed to, we admit you to the hospital, here's your prescription for homegoing antibiotics. We'll see you back in the office in 10 days or 2 weeks. That's what I take for holistic care, is that willingness to lean in and think about all of the things that impact that person's health and well-being.
And I would completely agree from the non-medical point of view, but from someone working from the nonprofit world, the last 10, 15 years, there has been a huge shift where our nonprofit has really collaborated with hospitals, specifically Metro Health, in the health disparities work. In being available to address housing needs, energy needs. If you're diabetic, you have to make sure they had refrigerators at times. Domestic violence, trauma, and not trauma in terms of just physical, but mental health. And so there has really been a shift, I would say, in the last 10, 15 years, where we've understood the power of the different aspects of someone's life in the community, the influence it had on their overall health. And if that we wanted to move the needle on someone's health outcomes, we must at the same time address what's happening in their homes and in their community to truly achieve the health outcomes we're looking for. So that's how I read it. And I think, it really captures what you've really captured what I thought in terms of its meaning. Is that address your question, Mike?
The reason I asked the question is because I've been a little confounded by not our work, but the notion of population health of, for example, who's going to be responsible for it in a local community. And because there's enormous requirement for leaders. This is very hard work. We know that. And it's very long-term in its nature. and it requires an extraordinary amount of facilitation and coordination. And the question is really, who is going to do that work? And I want to make sure we're clear at mental health side that we define the boundaries of where we are in that continuum of leadership. Do we want to position ourselves as that key leader that organizes it, or not, or something less than that? And what struck me when I listened carefully as Nancy read this, the notion stakeholders means everybody and anybody. Is that clear enough to us? And are we putting too much work or burden on us as Metro Health? I just want to make sure we don't do that. I believe that mission creep can be really a burden on all organizations, and being a little clearer about our boundaries of what we are and what we aren't can help us define that. And we may not be in a position to do that at this moment, but I would challenge us to be as clear and concise as we can so we don't overextend ourselves. So I don't know if this makes sense to you, but I'm worried about that. Mildly worried, I would say, not seriously worried.
I wholeheartedly agree with you. But if you read the sentence carefully, it says within the mental health system and the community served. And if you go back to what I described before about the Institute for Hope, it was for the health outcomes of our patient and our patient population. So we are very deliberate to not replace the public health institution and the community-based organization that are within the communities. And that's why we talk about partnership, because we want to partner with the others to achieve. But what really brings this all home is that we know now that the numbers can vary, but about 70 to 80% of what influence health outcome is not the direct care delivery that we provide in the hospital. So what this is really shining the focus that we have when we are trying to provide the care for our patient, and patient resides in the community. So that's why we talk about the community. We have to address them holistically and understand what are the other drivers of those health outcomes, and how can we remove, if there are any barriers to achieve the better health. So again, we truly should not be replacing the public entities, not the community-based organization, rather to collaborate with them on a better health outcome.
Thank you for that. Appreciate it.
Any other comments regarding the overall purpose of the charter? I thought that was a good question that makes sure that we're all on the same page and are defining it the same way. And I would agree, Dr. Chihata, that we are one of the collaborative leaders. This is collective impact. That means that we must work hand in hand with the community organizations, public health, and other hospitals to achieve this lofty goal, but it's a goal we must strive towards for equity in health across our region. Hearing no other questions around our purpose, we're gonna move on, but if something comes up, if you're like me, there's times that after I read it 10 times, I said, oh, I should have said this. Please feel free to put your thoughts in an email, because the rest of the board might not like hearing this, but this could be a living document in terms of that we're learning, growing, and there may be something that then needs to be added to continue to strive towards our ultimate goal. I'm gonna now move to our responsibilities, and I will, you should be thankful. I'm not gonna read them all. But I do invite you to review them again, or if you had a question about any of them, need clarification about any of these responsibilities, please feel free to bring them up now, because again, we're trying to get a very solid draft that we could then recommend to the full board.
I had one question, and it's really about one that's not here, that was sort of in the prior committee, and that was all around supplier diversity, which doesn't probably fit here, but where is it fitting somewhere else? Is somebody else sort of taking that on? Because that was a big part of what this committee looked at in the past. So.
So when we thought about that, we thought that that maybe was best. Some of what happens in that committee fits nicely in HR, and some of it fits in supply chain.
Okay.
And so we did some talking around that and actually
Right.
talked to the person who is running that program, and she
Right.
thought that the work she did aligned better with human resources.
So to be in my committee.
So that's coming your way.
Coming your way.
I just want to make sure it didn't get lost.
Yeah.
So-
Congratulations.
Yeah, no, once we teased it apart, because it seemed like it was a good fit with supply chain, but there's a
Even
lot of.
facilities too.
and-
Could be,
so
because so
great.
much of our spending is on capital things. So.
Fair enough, but she does a lot of work with the community and developing the, community and in the community, and so it just seemed.
Yeah, I just think it's important because I think everybody should benefit
Yeah.
from Metro Health.
Yeah.
And so that's, I think, important.
I think it's a really good point, and so happy to say that it's gonna be in your committee.
Thank you, Madam Chairperson.
But again, it could be fluid, so.
That's it. Whoever's not here.
So one of the things I do want to point out about the responsibilities is that I hope that you saw the hard work again that Dr. Marugo and his team put into this, and that the shift that we really are trying to focus on metrics, on best practices, research. I think that that's really going to help continue to drive us towards very specific goals. And I see it's taken a little bit more form in terms of being able to measure. If we can hold ourselves, we're gonna hold ourselves accountable by being able to measure our progress. And so that is something that I really like about this charter. Any other questions before we move on, or statements or recommendations?
I'm just also glad Dr. Golub's here because I think the work that they just sort of fit so nicely together. So I think that's important too, so.
I do want to highlight one specific aspect, which also has to do with the reframing, renaming of this committee, which was a recommendation. It's, and thanks to John Corlett for giving us some of the verbiage around that. If you look at the first bullet point under the responsibilities, I think that one actually encapsulates a lot of what Dr. Alexander has also been communicating in different ways and in multiple different forums, that our mission hasn't changed. The words may have changed, the way we talk about things may have changed, and John actually provided us with this language which talks about, and again, it's all really encapsulated, in my opinion, in a very succinct way in that first bullet point. And I would draw your attention to the very last piece of it, which talks about additional focus on groups whose outcomes fall statistically significantly outside benchmark range. And I think that's an important recognition. Those of you who, and the last time I think I was in front of the board with Matt Kaufman, was to talk about our ambulatory quality metrics and the targets, and we incorporated a measure of disparity within that. Sometimes it was payer, sometimes it was zip code, sometimes it was race, sometimes it was income level. But we acknowledge that there are statistically significant variations within populations. And by explicitly calling that out and saying that when we raise those populations which are lagging the farthest behind, we raise all boats. And that's going to be a fundamental element of how we are thinking about population health overall. So just wanted to highlight that one piece of it. So it's not lost in translation. It's not lost in all of the renaming and recasting of things that's happening too.
Yes, thank you for pointing that out. That was a really great suggestion, John, and thank you for helping us with the language. Hearing no other suggestions. Go ahead.
Yes,
please.
You want to be doing?
I don't know what you're gonna say.
Chair, there is one other edit that we were proposing to make to the charter. The next to the last paragraph on the subcommittees, we're asking to remove that paragraph. We talked amongst ourselves, and there's already a process for the board chair and committees chairs to assign work to staff members as well as to invite guests. So we didn't think there was a need for that paragraph.
Of the subcommittee paragraph.
Yes.
Yes.
And that, now you jar my memory that we did have this discussion before, so yes, that makes sense. So again, the recommendation is that we eliminate the subcommittee paragraph because there's already a process in place.
Correct.
That makes sense. So this will be part of the
Revised, yes.
revised recommendation that will go to the full board. Thank you for that. So next item on the agenda is to discuss the inclusion of community representatives within this committee, and I will ask Dr. Mulo to lead the discussion.
Well, thank you. One of the ways in which population and community health work really should be and could be most effective is to have the voice of our patients, of our families as part of the work itself. Given that we want to be inclusive, but there are barriers in including and incorporating patients and families into working groups and committees in the hospital. We wanted to have a discussion at this group as to what the recommendations would be. And again, I'm looking sort of at Dr. Gala because of the patient experience work that you do. How have we gone about incorporating those voices in a meaningful way? Especially because of the scope of this committee's work. It's going to focus on disparities, on populations that are disproportionately experiencing negative health outcomes. And we believe over and over again, the inclusion of community partnerships and stakeholders is called out. How do we do that in a meaningful way? When we looked at the membership of this committee, in fact, had a space in there to say community members. But then it came to the actual practicality of how do we incorporate patients, their families into this. And Kate, I know you do this work on a daily basis because of your FQHC leadership. We wanted to sort of bring it up at this group as well. Recommendations, I think, would be helpful. I'm looking at James. I think you may have had some conversations around in governance or.
Yeah, the governance committee is looking into this very issue. The Ohio Revised Code 33906 does grant the board the entire management and control of the county hospital. And so we read that to imply that the board may appoint folks from the community into the committee. The language in 339 does not prohibit the board from doing that. So we're reading it that it does. But there are a lot of things that are under consideration in the governance committee around this particular topic. A lot of things that we have to discuss, committee eligibility, which committees will have these, we call them advisory appointees. What should that process be, the vetting process for these individuals? And the approval, should it go through governance, should it go through the board, and how should that process work? We're also looking at the term length for these individuals and the onboarding process and how will they be trained. And then after all of that is done, we will have to amend our bylaws to allow for this process because it is not addressed in the bylaws. So the governance committee is looking into this. It's something that we're currently working on, and we'll probably have something to speak to probably September, October timeframe.
Yeah, and Nancy, Mike Summers here.
Yes.
As chair of the governance committee, and it's a great question, and I don't think it's appropriate for us to put bureaucratic processes in front of your work. So what I'd like to encourage you to do is to use the authority of the chair to create some ad hoc groups. You have the authority to do that, of whoever you think ought to be on that group, to do whatever work you need to do. I would ask that you be as clear to the assignment to that work and the outcomes expected, in fairness to the folks who are going to volunteer their time. But let's use the experience of this committee then to define what is the proper authority or bylaw changes that might be necessary. I think it would be appropriate to let our experience and the reality of that experience determine how we would want to shape the governance, not the other way around. We have to abide by the law. We're going to do that. We'll figure out any boundaries that we need to put on it, but let's use the broad mission of this committee as a good learning laboratory for us. So I would say, create your committees, call them ad hoc, which means temporary, they're informal, create the membership as you think is appropriate, define the work, and let's study how that needs to be shaped long-term. Does that make sense to you?
Yes, it does. And thank you for that. Because in particular, this committee, we really want to explore ways that we could bring authentic community voice to the process, to decisions, and through the actual work. But we also want to be mindful of some of the regulations and some of the laws. So it's a balancing act. So we'll probably work hand in hand with the governance team as we move forward, and also with our legal, so that we're always within boundaries, and probably go slowly at first to make sure that we can come to you, to the larger board, with a really good model on how to be able to balance between following the regulations and the law, and bringing in more and more a diverse voice to our decision-making processes.
One question I had.
I was just going to say, I think we could learn from this experience, but also common sense will say we're vulnerable to conflicts of interest. We're going to have to be watchful for that. We're vulnerable to accusations of unfairness. Hey, they got to participate, I did not. How did you pick them? Why didn't you pick me? So those are the things that James Wellens alluded to that we're going to have to be very careful about as a government agency or public official. And the definition of these volunteers may put themselves in a position, if we formalize it, as public officials. They may not want that. So there's a whole bunch of things that are ahead of us that could really snarl us if we're not thoughtful about it. But we have, I think, the liberty to say we're new at it. If we made a mistake along the way, or we didn't include somebody, we'll correct it. Sorry, we're learning how to do this better. And then we can formalize it to protect ourselves long term.
My question was going to be, my sense is that we have a number of community engagement activities already underway at Metro Health. And I'm just wondering if we could use those to sort of influence this committee, that we don't have to set up additional groups or whatever. I don't have a good sense of what all those are. But there may be already existing efforts underway that either with Ramona's work or other work at Metro Health. So
you read my mind. Thank you for that. Two things. Way back when we were setting up the patient-centered medical home, that was a requirement of the medical home of bringing folks in. And I have to say that the patients that I experienced, they felt very uncomfortable being in the medical setting, being on committees. But they were happy to be part of like a group discussion that happened in the evenings, or, right? So I would just say, let's bear that in mind. And this is a board of trustees, right? So I think how that might feel to someone that's a member of the community, it may not be the most comfortable way for them to participate. So I was thinking about that. And then also what we learned during our strategic planning process is that when we went out and spoke to the community, they were happy to share their voice, but they also shared the disappointment that there was no close the loop of, okay, well, what did you decide? Hey, could you get back to us? So I do know that is something that we have in mind as we roll out the strategic plan, and to continue to have those stakeholder meetings, that community engagement, to say, okay, how is this working? What feedback do you have? Now you've heard our plan. Now we're a year into the plan. Right? So I think we could easily integrate.
are any of the topics that we talk about in our charter reflected in any of that work? I mean, do those topics come up?
Some of it, not
Okay.
all of it, like the work around where it has the resident, around
Right.
recruitment and so forth. That doesn't come up directly, although we do hear a lot of feedback from the community that we would like to see physicians and APPs who are more
like us.
culturally appropriate, So that piece, but there are some elements mixed in, even if it's not specifically explicitly stated.
Ramona, you have your hand up? And then
Yes, thank you very much. I do think that we should be really thoughtful of how to include community into this. We've been talking as a team on what does maybe a new community engagement advisory committee made up of community members and smaller organizations or residents actually looks like. What is its scope and how does it function? Some of the work Tony's led through some hubs, hub and spoke model in certain neighborhoods and communities that helped us out with recruiting for like the health fairs. They're going to be hosting what we're working on are some community conversations over the next half of the year. And so we probably already have some already very committed community members who might be willing to serve at a higher capacity. I think what we could look at though is there, probably to Dr. Alexander's point, a smaller group of folks who meet and they have a representative that's an official that speaks on their behalf at this larger meeting. So, one of the mistakes we often make is that one person represents a community and they don't, they're communities, not community. But so how can we kind of connect those two things together?
Very good.
I'd just like to remind the committee that Metro Health has been a pioneer in the Patient Family Advisor Councils. So we have a very robust Patient Family Advisor Council throughout the organization that's run through patient experience. We have members sitting on every committee in the Institute of Patient-Centered Excellence, everything from reviewing my chart messages before they go and we actually turn them live, to talking about even patient harm. So we have talked nationally about our Patient Family Advisor Council here at Metro Health, both through Press Ganey and NRC. So we have a very robust pool that some have volunteered their time for over 10 years to Metro Health and have been on it since the beginning of the committee findings. So we always have that to utilize as well. As you're talking about engaging, community members, that's a total community organization, if you will, that strives on improving the quality, safety, and experience of care at Metro Health.
So what I would add to that is that, and Dr. Walker can chime in here, is we have this on the FQHC side. The primary tenet of a federally qualified health center is that you have a 51% majority patient-led board. And we took that very seriously, and they are patients of the health center. So the sites that are aligned with the health center, our patients represent those sites. They oftentimes come to main campus for other things, but they are primary care patients first and foremost of our community-led sites. They were recruited through our patient and family advisors, and then through Ramona's work in the community of how we balance that out. We have one member that serves both on both boards. Now that's Dr. Walker. So we have established a way in which we can move information between the FQHC board and the system board. I don't know that we've ever really talked about, outside of Dr. Walker, of looking at our patient representatives and if they can serve, if there's a place for them to serve through the broader board of trustees. And I would defer that back to the system side and to this group to look at it from that perspective. But I think there is a line of communication directly to our community through that board and through the process that we put that board together.
And also, we have our accountable care organization that takes care of our Medicare fee-for-service. Our board has a requirement and a composition and a representative from the community. So this is not something new. It is in the bylaw of that board structure as well. And we have that in place. But I also want to suggest a couple of small edits. Institute for Hope at the end of the E, there is a period, and that's very important. And there's a trademark, missing that needs to be there. Sorry about that. And population health has to be a little bit more defined. We don't have an entity called Population Health. It is Population Health Innovation Institute or Population Health Research Institute. So it's either or both, but it's not just population health.
That's good. Thank you for that. Anyone else?
Before you guys end that discussion, I just want to say, we talked ad nauseum about having community members on our committees and the governance committee, the last governance committee. I just want to caution everyone. I don't know who said it about the compliance, conflict of interest things, depending on what type of community member chooses to be involved. And I do think that we do have a lot of other community focused groups. So I think that we should just look at that a little bit more and maybe talk about this at your board retreat in October.
Tamika, you read my mind. As I was listening to all of the different comments, there seems to be a lot of existing groups, committees, and voices that we could tap into as needed to help us make sure that on an ongoing basis, we are receiving the community voice. Because this is complex, and it's one of the reasons why before we talked about it at the governance board, we already had it on our agenda, because it is important to be of the community, but there's different ways to be able to achieve that, not necessarily having to bring someone officially on a committee. But we wanted to have this discussion for that very reason, so that we can hear about this group, this committee, this way that will help us determine what is the best way forward, because it is complex. It is nuanced. There are Ohio revised codes that we must follow. So it's not as simple as, say, if I wanted to add a community person on my nonprofit, I just put them on. This is much more complex. And so we want to be very thoughtful in our in the discussion and in the next steps. There's a lot of good suggestions here that would help us to have other options. But we will get back to you, because this is a broader board conversation, because we're always talking about community voice. And we do have, as Tamika just spoke of, a retreat coming up where I promise we will talk about this more in depth. But thank you for all the suggestions, because I feel confident that we have other ways of getting that community voice within this committee. So thank you for that. I'm going to hand it over one more time to Dr. Marugu for our next steps, because I forgot to write them all down.
Really, there's only one big next step that we wanted to talk about, which was following the formulation of the strategic plan. We in this instance being BJ, who's in the room, and Dr. Moreland, who's on virtually, have been working on translating some of the work around that was in the health equity pillar into the work that will go into this future population community health work. And as we have gone about translating the concepts, the principles, and the sort of the consensus that developed around that pillar into what will be action steps going forward, BJ, Dr. Moreland, and I are fairly close to presenting a draft of what a roadmap might look like for what the work of this committee will be. And we'd like to suggest that we have a dedicated meeting, an ad hoc meeting. This committee is scheduled to meet quarterly at least, but we would like to ask for a meeting about 4 weeks out from now in order to be able to have a discussion around that. Maybe an hour-long meeting would be adequate, really. We can share material ahead of time. We have it fairly formed. I'm gonna say it's about between, what would you say, BJ, 80%? Ish. There you go. Yes. Makes it more believable when you throw in something. So that really was the main item under that, Nancy, is to request that if we could have a dedicated meeting to discuss that strategic roadmap for this one.
Yes, and we will invite everyone on the committee. If you cannot make it, that's fine. But we really felt that we needed one more meeting between our quarterly meetings to really have a much more from 82%, we're trying to get to like 99% done. And so we would like to present that in an hour meeting, just review it. So that will be going out. I'll ask my my friends that are very important here, Tamika and Veronica, to help with scheduling. So you will be seeing a meeting request shortly. And if you can make it, we'd love to have you as part of that conversation. Thank you. At this time, we're going to move to executive session to discuss hospital trade. Usually there's a paragraph that I don't have. And now I do.
Over here, Nancy, that starts off a little differently.
At this time, we are going to move into executive session to discuss hospital trade secrets as defined by Ohio Revised Code 1333.61. Do I have a motion to recess in the executive session to discuss these matters? So moved. Second,
Second.
so now I'm gonna read the roll call. I don't see Arnold, Reverend Arnold? Yes. John Corlett?
Yes.
Sharon Dumas?
Yes.
Ron D?
Yes.
Lola Garcia?
Yes.
Nancy, I vote yes. Michael Summers? That was a yes, Mike? Yep, all right. And Dr. Walker?
Yes.
We have,
So you can say at this time we'll move into executive session.
at this time, we're moving into executive session. I love you.
Now back in public session.
Thank you. So the last order of business is to approve the recommendation for the approval of restatement of name and charter of the Health Equity and Diversity Committee to be presented for full board approval. Are there any additional comments? Hearing none, do I have a motion for approval?
So moved.
Second? Second artist?
Aye.
Any opposed? Oh, that was Dr. Walker, sorry. Any opposed? Hearing none, motion passes. With there being no further business to come before the committee, the meeting is adjourned.
Just so you know, there's like a little fan on the side of that podium thing.